Welcome to Outbreak Brief, the podcast that takes you inside the world's most dangerous infections. Today we're tracking a pathogen defined by a really unsettling contradiction.
Yeah, it's a pathogen with a true split personality.
Right, because on the surface, it just masquerades as a mild, fleeting childhood illness. You get a minor fever, a faint rash, something your immune system basically swats away in a weekend. But beneath that harmless exterior lies this silent, devastating agenda against the most vulnerable population on Earth, which is the unborn. Today, we are exposing Rubella.
And it really is a virus that weaponizes stealth. I mean, it slips into a community completely unnoticed, and it leaves behind this trail of catastrophic developmental damage that, well, we only see months after the virus has already moved on.
I want to take you back to the United States in the spring of 1964. A highly contagious respiratory virus is just sweeping through the country, and for most people, it's barely a nuisance.
Yeah, you might get a slight sore throat, maybe some swollen glands.
Yeah. Right, and a pink rash that vanishes in 3 days. People are going to work, they go to the grocery store, they go to school. But the true horror of this outbreak didn't become clear until the following winter.
In delivery rooms across the country.
Exactly. That mild 3-day rash had actively crossed the placentas of thousands of pregnant women. It resulted in 20,000 babies born with irreversible brain damage, deafness, and heart defects, and caused over 11,000 fetal losses. It's like a biological Trojan horse.
And while that specific epidemic is history, the global reality today is still staggering. Every single year, an estimated 100,000 infants worldwide are born with what we call congenital rubella syndrome, or CRS.
100,000.
Yeah. A mother barely notices she's sick, completely unaware that this microscopic invader is actively altering the architectural blueprint of her developing baby's eyes, heart, and brain.
It's just a total infiltration. But before we get into the human toll of all this, we really need to understand what exactly we're dealing with. So what is this virus and, how is it built?
Well, we're dealing with the rubella virus, and biologically speaking, it's entirely unique. It is the single, solitary member of the rubevirus genus.
The only one.
The only one in that genus within the togavirus family. If you look at it under an electron microscope, you see this tiny spherical particle wrapped in an outer envelope. And inside that envelope is its genetic code, which is a single-stranded, positive-sense RNA genome.
Okay, let's unpack this because positive-sense RNA sounds like some pretty heavy virology jargon. Does that mean the virus essentially comes with pre-formatted instructions?
That is a great way to think about it, actually. The genetic code of this virus is already formatted exactly like our own cell's messenger RNA.
Oh, wow.
Right. So the moment rubella breaches one of your cells, it doesn't even need to unpack or translate its code. It just hands its genome over to your cellular machinery, and your own cell blindly starts printing viral proteins instead of doing its normal job.
So it turns our own cellular factories against us immediately. How does it physically break into the cell in the first place, though?
It uses two highly specialized surface proteins. We call them the E1 and E2 glycoprotein spikes. These stick out of the virus's envelope. E2 helps maintain the structure, but E1 is the actual lockpick.
Okay.
It's a class 2 fusion protein, and it has a very strange quirk. It absolutely requires calcium to function.
Wait, really? Calcium?
Yeah. When the virus approaches a human cell, the E1 spike actually binds with the calcium ions that are naturally floating in your extracellular environment. And that calcium triggers a shape shift in the spike. It acts like a molecular crowbar that forces your cell to swallow the virus whole.
Through endocytosis.
Exactly.
Wait, so it uses the calcium in our own bodies to power its break-in? That's like a burglar using the battery from your own smart lock to bypass the front door.
It is an incredibly elegant, highly evolved piece of biological machinery. And for centuries, that machinery operated on a relentless clock.
Let's talk about that history, actually, because a lot of people listening probably know this virus by its older nickname, German measles. Is this just some variant of the measles virus that originated in Europe?
Not at all. Calling it German measles is a massive historical misnomer.
Oh, really?
Yeah, it got that name simply because it was first described in detail by German physicians in the mid-18th century. They noticed it looked a bit like measles but behaved differently.
Right.
Biologically, rubella and measles are completely different families of viruses. They're structured differently, and the diseases they cause have entirely different endgames.
And before modern medicine intervened, this wasn't just a rare, sporadic disease. It was a guaranteed cyclical event.
Or absolutely. We saw massive global epidemics every 6 to 9 years. The virus would roll in, usually peaking in late winter and early spring, with the highest infection rates hitting children between 5 and 9 years old. It was a predictable tide. Before the first vaccine arrived in 1969, up to 4 in every 1,000 live births in some areas were affected by congenital rubella syndrome.
That is a terrifying statistic to just accept as a normal part of human reproduction. How was it spreading so fast to keep that kind of cycle going? What's the transmission route?
It's an airborne respiratory pathogen, so it's transmitted through droplets and close personal contact. When someone infected with rubella coughs, sneezes, or even just talks, they launch these aerosolized particles loaded with the virus into the air.
Just waiting to be inhaled by the next host.
Exactly. And once inhaled, the incubation period is notoriously long. It's typically 14 to 21 days before any symptoms show up.
Okay, here's where it gets really interesting, because the incubation period is long, but the truly alarming part is the infectious window. Based on the data we have, an infected person is contagious for up to 8 days before they ever develop a rash, and up to 8 days after. How is someone shedding a virus for over a week before they even know they're sick?
Because the virus doesn't trigger a massive systemic alarm right away. When you inhale it, rubella quietly sets up shop in the respiratory epithelium, the lining of your throat and airways,
Yeah.
and in your local lymph nodes.
It's just flying under the radar.
Exactly. It replicates there silently, building up huge numbers. By the time it launches into your bloodstream, what we call primary viremia, and causes a fever or a rash, you have already been exhaling millions of viral particles into your community for a week.
That is wild.
And furthermore, up to 50% of people who catch rubella are completely asymptomatic. They never get the rash at all.
So you have half the infected population walking around feeling absolutely fine, silently acting as super spreaders. It sounds invincible, but it does have an Achilles heel outside the body, doesn't it?
It does, thankfully. It relies entirely on fast, efficient, human-to-human jumping, because the virus itself is quite fragile in the environment.
Oh, really?
Yeah, it's easily destroyed by heat over 56 degrees Celsius, by ultraviolet light from the sun, and by extreme pH levels, so it cannot survive long on a park bench or a doorknob. It absolutely needs the warm, protected environment of a human host.
Which brings us to the most critical part of this entire deep dive, and that is who is most at risk. Obviously, an unvaccinated child or adult is going to catch it, but the ultimate target, the one that suffers the truly catastrophic consequences, is the developing fetus. Specifically, if a pregnant woman is infected during her first trimester, so the first 12 weeks of gestation.
Right, because those first 12 weeks are the critical window of embryogenesis. This is when the foundational architecture of the fetus's organs is being laid down. If a mother contracts rubella before 10 weeks gestation, the fetus has up to a 90% chance of developing severe, lifelong defects or facing fetal death.
90%. I really want to unpack the biology of that destruction, because why does the fetus suffer so profoundly when the mother's immune system barely registers the infection? What is the virus actually doing once it crosses the placenta?
It comes down to targeted cellular sabotage. When the virus is in the mother's blood, it attacks the placenta directly. It causes necrosis or tissue death in the tiny finger-like projections called chorionic villi that supply nutrients.
Okay, so it cuts off the supply line.
Exactly. And once the virus crosses into the rapidly developing fetus, it unleashes two major weapons. First, it triggers apoptosis, which is programmed cell death. It commands the fetal cells to essentially self-destruct.
It's actively killing the fundamental building blocks.
Yes. And for the cells, it doesn't kill, it inhibits mitosis. That's the ability of a cell to divide and multiply. It does this by physically disrupting the intracellular actin assembly in the fetal cells.
Wait, actin assembly, what is that?
Actin is a protein that acts like the structural scaffolding of a cell. By breaking down that scaffolding, the virus literally freezes cellular development.
So if you think of fetal development as a massive construction site, the virus isn't just killing the construction workers, it's tearing down the scaffolding and halting the delivery of bricks.
That's a perfect analogy. And it also causes severe vascular damage. It degrades the developing blood vessels, leading to organ ischemia.
Meaning lack of blood flow, right?
Right, meaning the newly forming tissues are starved of blood flow and oxygen. The organ simply cannot grow. Today, this devastating chain of events is heavily concentrated in regions of Africa and Southeast Asia, simply because vaccine coverage in those areas remains dangerously low.
Let's talk about what this disease actually looks like on the outside, because as we said, it presents as two completely different realities. We know half of people show no symptoms, but for the adults and children who do get sick, What are the warning signs?
For a child or an adult, it begins with a mild prodrome. So low-grade fever, fatigue, and swollen lymph nodes. And the swelling is very specific, usually the postracheal nodes right behind the ears and the suboccipital nodes at the base of the skull.
Okay.
You might see mild pink eye. And a doctor might also spot Forchheimer spots, which are these tiny pinpoint red hemorrhages on the soft palate inside the mouth.
And then the signature rash appears.
Right, a pink maculopapular rash, meaning flat red areas covered with tiny bumps. It typically starts on the face and spreads rapidly down the chest, trunk, and limbs. After about 3 days, it fades away in the exact same top-to-bottom sequence it appeared.
So for most healthy adults, you stay home, you rest, and it's over. Though we should note that up to 70% of infected women experience severe joint pain and arthritis that can actually linger for weeks.
Yeah, the arthritis is very common in adult women.
Right. But it's mostly a nuisance. But contrast that mild inconvenience with the reality of an infant born with congenital rubella syndrome. I mean, it is a completely different universe of suffering.
It is. The hallmark of CRS is a tragic triad of conditions. Sensorineural deafness, blinding cataracts in the eyes, and severe congenital heart defects.
Wow.
A very common one is patent ductus arteriosus, where a vital fetal blood vessel fails to close after birth, which leads to heart failure. Deafness is the most common outcome, though. Sometimes it's the only sign of infection. But babies can also suffer from microcephaly, profound intellectual disabilities, and liver damage.
The clinical descriptions in the medical literature are just heart-wrenching. I mean, doctors often look for what is called a blueberry muffin rash. Can you explain what is actually happening in the newborn's body to cause that?
Yeah, that rash is a visible sign of profound internal failure. The medical term is dermal erythropoiesis.
Dermal erythropoiesis.
Right. Because the virus has so severely damaged the bone marrow's ability to produce blood, the infant's body desperately tries to manufacture blood cells in the skin instead.
Oh my God.
This leaves dark, purplish-blue spots all over the newborn's body. And if you take an X-ray of their limbs, you also see what radiologists call celery stalking.
Celery stalking.
Yeah, alternating bands of dark and light in the long bones, showing exactly where bone growth was repeatedly disrupted and stunted by the virus during pregnancy.
That is just brutal. Knowing how systemic and destructive this is, what are the treatment options? If a patient is diagnosed with rubella today, what can medicine actually do?
Well, this is the harsh reality of many viral infections. There's no cure. There's no antiviral pill you can take to clear rubella. For an adult or a child who catches it postnatally, it's strictly supportive care. Bed rest, hydration, and NSAIDs like ibuprofen to manage the fever and the joint pain.
But for an infant born with CRS, how do you even begin to treat a child with that level of multi-system damage?
You don't cure the virus. You manage a lifetime of disability. It requires an incredibly complex interprofessional medical team. Pediatricians, cardiologists to surgically repair the heart defects, ophthalmologists to remove the cataracts, audiologists to manage the deafness, and long-term developmental specialists.
I have to ask about the aftermath of a CRS birth. If an infant survives the delivery and is living with these defects, is the virus finally gone from their system?
No, and this is actually one of the most critical infection control challenges in neonatology. Infants born with CRS act as living viral reservoirs.
Meaning they're still contagious.
Very much so. Because their immune systems were so severely compromised during development, they cannot clear the pathogen. They can actively shed live contagious rubella virus in their urine and their respiratory secretions for a year or more after they are born.
A full year. You have an infant in a neonatal intensive care unit surrounded by pregnant healthcare workers, and that baby is actively contagious for their entire first year of life. That is terrifying, which makes the antidote to all of this, the vaccine, not just a personal choice, but a strict societal necessity.
Absolutely. The modern defense is the MMR vaccine, covering measles, mumps, and rubella, or the MMRV, which adds varicella. In the United States, we use the live attenuated RA273 strain.
Okay, let's clarify what live attenuated means for the listener, just to be sure. The virus in the vial is technically alive, but it's been weakened in a lab, so it can't actually cause the disease. It basically just acts as a sparring partner for your immune system, right?
Precisely. It mimics a natural infection just enough to trigger a robust, lifelong cellular immune response without causing the illness. It's a masterpiece of public health engineering. It's exceptionally safe, and a single dose is about 97% effective at providing lifelong immunity.
That's incredible efficacy.
It really is. The standard schedule for children is 2 doses. The first at 12 to 15 months and the second between 4 and 6 years of age. Interestingly, there is a historical group that needs to be careful.
Oh, who's that?
Well, if you received the early killed virus measles vaccine between 1963 and 1967, it did not provide lasting cellular immunity, and you actually need to be revaccinated with the modern live version.
That is really good to know. Let's say someone is listening to this, they realize they aren't vaccinated, and they find out they were just sitting next to someone with rubella on a train. Can they rush to a clinic and get the MMR shot as an emergency plan B, like post-exposure prophylaxis?
Unfortunately, no.
Really?
Yeah. With some viruses, like measles, getting vaccinated within 72 hours of exposure can sometimes blunt the infection. But the MMR vaccine has not been shown to be effective at preventing rubella after an exposure has already occurred. By the time you know you've been exposed, the virus is likely already replicating in your lymph nodes.
Right, because of that silent incubation.
Exactly. Furthermore, because the vaccine contains a live virus, it carries a theoretical risk to a fetus. So it is strictly contraindicated during pregnancy. You absolutely cannot give the MMR vaccine to a pregnant woman.
Wow. Okay, so the only true defense is getting vaccinated well before you are ever exposed, and certainly before you ever plan to become pregnant. Which brings us to the massive invisible protocols that hospitals and public health systems use to keep us safe. What does that look like?
Prevention relies heavily on maternal screening. When a woman becomes pregnant, checking her IgG antibody titer, her immunity levels to rubella, is a standard of care.
Just to make absolutely sure she's protected.
Right. And if a blood test shows she is not immune, her doctors monitor very closely to prevent exposure, and she must be immunized immediately after giving birth to protect any future pregnancies.
And think about those CRS babies in the hospital we talked about earlier. Since they are shedding the virus for over a year, neonatal intensive care units have to implement intense contact isolation. Doctors and nurses practice relentless hand hygiene and droplet precautions just to prevent nosocomial or hospital-acquired outbreaks. It's really like building an invisible biological firewall around the most vulnerable people in the building.
It is.
And every person who gets vaccinated adds a brick to that firewall, blocking the virus from reaching a pregnant mother or a newborn.
And when that firewall is strong, it works beautifully. Through aggressive, sustained vaccination campaigns, rubella was officially declared eliminated from the United States in 2004 and from the entire Americas region in 2015.
So what does this all mean for you? If you live in the Americas or much of Europe, we're doing a deep dive on a disease that is supposedly eliminated. Why should we still care?
Because in epidemiology, eliminated absolutely does not mean extinct. Elimination simply means that continuous year-round transmission within a specific geographic border has been interrupted. But the virus is still circulating widely across the globe. In 2022 alone, there were nearly 18,000 reported cases across 78 different countries.
And in the era of high-speed global transit, a virus replicating in a community across the world is only a 12-hour flight away from landing in your city.
The math is unforgiving. To maintain herd immunity against rubella, a community needs to keep its vaccination coverage between 80 and 85%. If vaccine hesitancy causes coverage to dip below that threshold, a single infected traveler walking through an airport can spark a devastating local outbreak.
Which brings us to the future. What are the big global health organizations doing to stop this virus globally?
The global pipeline is highly ambitious. The Measles and Rubella Partnership, which includes the WHO, CDC, and UNICEF, is operating under the Immunization Agenda 2030.
Okay, and their goal is?
Their primary goal is to maximize the reach of the vaccine, aiming to avert over 50 million deaths from these diseases this decade. And the progress is real. By 2025, 179 out of 194 countries had integrated the rubella vaccine into their national health programs.
That is massive logistical progress. But it raises a psychological concern, I think. Are we risking becoming victims of our own success? If new parents today have never seen a baby with a blueberry muffin rash, if they don't know a single person who went deaf from a maternal infection, will they simply stop seeing the value of the vaccine?
That is the ultimate vulnerability in modern public health. We have mapped the genome. We understand exactly how the E1 spike uses calcium. We have a vaccine that is practically flawless. The virology is solved.
Right.
The biggest remaining unknown is human memory. Can humanity sustain its defensive walls across generations who have never had to witness the horrors of the disease firsthand?
It is a profound realization, and I want to leave you with one final chilling thought to mull over. We talked earlier about how the rubella virus relies entirely on humans. It has no animal reservoir. There are no bats, no birds, no mosquitoes harboring this pathogen in the wild. That means the only thing keeping this virus alive on planet Earth is our own failure to protect one another. The virus is simply waiting patiently in the shadows, hoping for our collective amnesia to set in.
The tools for eradication are entirely in our hands. It's up to us whether this virus survives another century or finally fades into history.
Stay informed, stay prepared. This has been Outbreak Brief.